Good afternoon, all. In today's webinar, we'll be discussing about non-invasive positive pressure ventilation. Over the next 30 to 40 minutes, we'll be discussing about the various indications of use of NIPPV in neonatal care, the difference between synchronized and asynchronized form of NIPPV, various settings depending on the disease, evidence for use of NIPPV, and finally a practical approach. The NIPPV is a mode of ventilation without using an endotracheal tube, and it uses an interface which is either placed at the nares or seals the entire nose with a mask. So the main difference between an NIPPV and invasive ventilation is avoiding endotracheal intubation. Coming to the non-invasive respiratory support, there are 6 modalities of non-invasive respiratory support, the common ones being CPAP and HFNC. We'll be discussing about NIV today. The other modalities which are there include BiPAP, which is also sometimes considered as a part of NIMV or NIPPV, and the two newer modes, that is the nasal HFO and NAVA. If we classify these modes depending on the pressure generation, they can be broadly divided into constant airway pressure or variable airway pressure devices. The NIPP comes under variable airway pressure devices, and we'll be discussing more about NIPPV in subsequent slides. Now, we know that CPAP has been the backbone of respiratory support, and it is useful as well as does not have majority of the complications associated with invasive ventilation. Then why do we use NIPP, or why do we need NIPP? It is because that despite CPAP being an excellent modality, it does not work in patients with poor respiratory efforts, especially in apnea, and 40 to 60% of the babies with RDS may fail CPAP, especially the VLBW babies. Also, the babies who get ventilated and are extubated, 25 to 40% of the intubated babies will fail extubation to CPAP and may get reintubated. And we know that reintubation is associated with both impaired short and long-term outcomes. On the other hand, ventilation is known to cause various forms of lung injury, such as volume trauma, barotrauma, rheotrauma, which are bundled under the term VILI, or ventilator associated lung injury or ventilator induced lung injury. Also, ventilation has been shown to be associated with increased chance of systemic as well as lung infection, commonly known as VAP or ventilation associated pneumonia. And we also note that even after extubation, the babies may have various morbidities related to ventilation, such as subglottic stenosis. And invasive ventilation in itself is one of the important predictors of BPD. Therefore, we need something which can overcome the shortcomings of CPAP and which avoids ventilation associated side effects. For that, the modality known as NIPP was devised to help the babies who are likely to fail CPAP and prevent them from going on to ventilation. The NIPPV, in addition to the CDP, that is constant disturbing pressure, gives intermittent ventilation driven breaths with PIP, that is with preset pressures and at prefixed rates. And these ventilator driven breaths can be synchronized with patients' own respiratory efforts, where it is called as synchronized NIPPV, depending on the type of device which we are using. Now, the actual mechanism of action of NIPPV is not known, but there are various postulates by which NIPPV is believed to act. One of the mechanisms includes it augments respiratory support by Head's paradox reflex. which states that whenever there is sudden distension of the lungs, it induces a gasp or deep inspiratory effort, which is mediated by the irritant receptors of the major airways. This reflex is important to generate FRC and is predominantly seen within the first 1 or 2 days of life. Also, because of the higher pressures, that is PIP, it leads to sustained alveolar ventilation and establishment of FRC. Also, in few of the studies, it has been shown to increase the tidal volume, especially with synchronized forms of NIPPV, and it decreases lung inflammation. We, it was also shown to decrease work of breathing and prevent distortion of rib cage. The asynchrony, as shown in the diagram, which is seen with the nasal CPAP between the thoracic and the abdomen, is not seen in NIPPV, especially the synchronized form. Better synchrony means more patient comfort and decreased work of breathing. One of the common reasons for CPAP failure is apnea, and NIPPV, by generating higher pressures compared to CPAP, dilates the muscles of pharynx and thus release obstructive apnea. It is also postulated that because of the high flows, the soft palate is pushed against the tongue, leading to the sealing of the oral cavity, and this in turn again leads to decreased obstructive apnea. The head's paradoxal flex, as we have already discussed, leads to augmented inspiratory drive and thus is also beneficial in central apnea. Now we all know that oxygenation depends on mean airway pressure, and mean airway pressure is largely determined by PEEP and PIP, and NIPPV gives both, that is PEEP as well as PIP. Therefore, it leads to better oxygenation. Also, since we are not intubating the baby, the natural protective mechanism, that is the grunt, which is used to establish FRC or generate PEEP, is intact. All these mechanisms leads to better oxygenation for a baby who's on NIPPV compared to CPAP. A word about synchronized form of NIPPV. Synchronized machines are not easily available, and synchronization itself is a tedious job because the various devices which are used for synchronization are affected by the leak or water in the circuit, and also the placement of raspberry capsules in itself is a big challenge. Although various studies have shown that synchronized form of NIPPV leads to better tidal volumes, but only 15% of the babies have been shown to get actually higher tidal volumes. Also, non-synchronized NIPPV has been increasingly used around the globe, and it has been shown to be beneficial. So as of now, there is no different consensus regarding which one is better. Both can be used if available. Synchronized form should be preferred, but asynchronized seems to be effective and safe. A word about devices or techniques used for synchronization. These are usually of two types. The previously used raspberry capsule was highly sensitive and was not affected by the leak around the circuit or water in the circuit. However, it was affected by the paradoxical movements of the abdomen, abdominal distension, and also it did not tell us about the tidal volume measurements. This led to establishment of other techniques such as differential pressure flow transducer and hot wire anemometer, which are easy to place and are placed between the NIPP interface and the ventilator circuit. They are highly sensitive, have short response time, but they are affected by the leak around the circuit and the water in the circuit. Also, they are known to increase the dead space. A word about BiPAP, which is sometimes also considered as a part of NIPPV. In BiPAP, there are two levels of CPAP pressure, which are different. That is the difference of 3 to 4 between the high and the low pressures, and patient can breathe both during high pressure as well as low pressure, as is shown in the diagram on the left. The pressures are usually lower as compared to the NIPPV, and the TI is usually longer than 0.5. Whereas NIPPV mimics invasive ventilation, it gives PIP, and there is PEEP with the pre-specified rates and pressures. There are various interfaces just like CPAP, and one can use whatever is available or whatever the team is comfortable with. Nasopharyngeal tube is largely obsolete because it gets frequently obstructed by the secretions and it is more invasive than the other modalities. Not much has been studied about the interfaces vis-a-vis NIPPV, but recently, last week, there was a study published in JAMA Pediatrics where they compared long narrow tubings with short binasal prongs and mask. It was a non-inferiority randomized controlled trial with a non-inferiority margin of 15%. And the authors concluded, and the study showed that the long and narrow tubings, that is the Ram's cannula, which was used in the study, is equally good compared to binasal prongs and mask. And in fact, Ram's cannula was associated with less nasal trauma, that is only 5% compared to the 17% in binasal prong and mask group. Therefore, one may prefer Ram's cannula for delivering an NIPPV if it is available. An NIPPV is mainly used for post-extubation and apnea of prematurity, and it is less commonly used as a primary mode for respiratory disorders in majority of the centers. The knobs which one has to set for starting an NIPPV include PIP, the adequacy of which is seen by the adequacy of chest rise, saturation, and partial pressure of the carbon dioxide. Then we have PEEP. The adequacy is determined by the absence of retractions, good lung expansion on the chest X-ray, which is defined as lung space of 6 to 8, and the normal saturation. Then we have to set rate, which depends on the respiratory drive and the partial pressure of the carbon dioxide. Then we have to set FiO2, as is seen with other respiratory supports. It is governed by the saturation and partial pressure of oxygen in the blood gas. Flow and TI usually are fixed. Flow of 8 to 10 liters and TI of 0.3 to 0.5 is used. For post-extubation, the PIP use is around 16 to 18, or same as that on the ventilator. It is increased by 2 centimeters of water to account for the air leak around the nose and the mouth. PIP of 5 to 6, rates of 20 to 30, and TI of 0.3 to 0.5 are usually used. The evidence for use of NIPPV in post-extubation comes from the recent Cochrane published in 2016 construct around 10 trials. Around 1400 babies were studied, and it showed a significant reduction in reintubation by around 25%. It also decreased incidence of air leak by around 50%, and there was no difference in complications. However, there was no decrease in BPD or death. Also, in many of the babies, the baby has already received surfactant before starting them on NIPPV. Also, this NIPPV consists of both synchronized and non-synchronized forms. And the babies who failed CPAP were directly ventilated. Whereas majority of us in our day-to-day practice, whenever a baby fails CPAP, we give him a trial of an NIPPV. So these points have to be taken into consideration before interpreting the results. Recently, a trial was published in May 2020 in Neonatology, where they compared non-synchronized NIPP with CPAP for post-extubation in the LBW babies. They studied around 220 babies with a mean gestation of around 28 weeks, and there was no difference between the non-synchronized NIPPV and the nasal CPAP. For RDS, the PIP is used as around 18 to 22 depending on the severity of the disease, or 10 centimeters above the CPAP. PEEP of 5 to 6, rates of 40 to 50, and TI of 0.3 to 5, 0.3 to 0.5. very much similar to the ventilatory settings. Now, the evidence is again comes from the Cochrane, which consists of around 10 trials, 1,000 babies. It showed decreased need for intubation by around 30%. However, the confidence was almost nearing 1, and there was no increased risk of complication. Again, it did not show a significant reduction in BPD. Since NIMV requires ventilation, that is a ventilator machine which is costlier and is not available at all centers, especially in developing countries, and the evidence is low to moderate grade. CPAP still remains the modality of choice as a primary support for RDS. Again, recently a trial of 84 infants with mean gestation of 29 weeks was published, where they compared synchronized and NIPPV with CPAP as a primary modality for infants with respiratory distress syndrome. With the use of NIPPV, the authors showed a significant reduction in the need for intubation. That is, it was 11.9% compared to 40.5% seen in the CPAP group. As of now, although there is some evidence which shows that NIMV is better, but this evidence is not enough to allow us for changing the practice and shifting from CPAP to NIMV. In apnea, very minimal settings are used because the lungs are normal, and the evidence is usually limited. The recent Cochrane the last meta-analysis was published in Indian Pediatrics in 2016, and in this meta-analysis, the authors showed that NIPP is associated with decreased number of apneic episodes in premature babies, but there was quite heterogeneity among the studies. So more data, more evidence needs to be generated in this regard. The possible complications, as is true for other non-invasive respiratory support, includes nasal injuries, which can be seen between 20 to 60% of the babies. This can be largely avoided by good nursing care, use of proper size masks, and use of barrier cream and dressings before application of the interface. Abdominal distension because of the aerophagy is possible, and one should always ensure placement of an orogastric tube for any baby who's on any form of respiratory support. There are a few reports of air leaks and pneumothorax with the use of NIPPV, but majority of them were because of the primary lung condition rather than NIPPV. There are very few anecdotal reports of subcutaneous emphysema, gastric perforation, NIC, and NEC, but these have not been shown to be associated with NIPPV in large randomized controlled trials. When should one consider ventilation for a baby on NIPPV? If a baby has significant respiratory acidosis, which is defined as pH of less than 7.25, PCO2 of more than 60, baby has recurrent apnea despite being on caffeine, which requires bag and mask ventilation. Despite reaching maximal settings, baby is still not maintaining saturation, then one should consider ventilation. Now, the maximal settings vary from center to center and vary from country to country. Usually, the maximum pressures before shifting the baby to the ventilation are between 20 to 24 centimeters of water. Now, when should one be in? Similar to ventilation, whenever with the baby is hemodynamically stable, his milieu interior is normal, he's on minimal settings, that is PIP of 12 to 14, PIP of 4 to 5, and FI2 of 30% or less, he should be weaned from NIPPV. Some of the points about troubleshooting. In majority of the ventilators, especially in the non-synchronized form, there will be a continuous flow sensor alarm. So remember that flow sensor has to be taken out of the ventilator circuit. If a baby is fighting the circuit, then one should ensure that baby is having adequate size prongs in place and they are in position, and always give some non-pharmacological measures like mother's milk, colostrum, facilitated tucking for pain or discomfort. If there is a alarm showing leak in the hose or disconnection alarm, make sure that there is no leak around the interface or in the circuit. And if despite correcting for any leaks in the circuit or interface, it is still continuing to give alarm, then one should decrease the set pressures to the measured pressures shown on the ventilator. This is because sometimes because the large leak, one is not able to achieve or deliver higher pressures. So one has to come down on PIP. Finally, a summary of respiratory support. Whenever a preterm baby has RDS or apnea, he is started on CPAP. If there is CPAP failure, then one should consider NIV. And if only there is NIPPV or NIV failure, then one should go on to ventilation. Post-extubation, especially in VLBW babies, NIV can be tried, and it has been shown to decrease chance of reintubation. To conclude, in comparison to nasal CPAP, NIPPV decreases the frequency of post-extubation failure, especially in VLBW babies. NIPPV should be used as a rescue mode before jumping to the ventilation. Remember that ventilation or lung protective strategy is a bundle of interventions, and no single device or mode is a magic bullet. That is, one has to ensure that the baby receives antenatal corticosteroids. We use non-invasive respiratory support. We use caffeine and other modalities in combination to get good outcomes. Thank you.